Desai, sir.
Yeah.
Okay,
Yes, sir.
as usual, I will start with a prayer and then thank you. First, I'll thank Ma Saraswati and then we will go ahead. Really thankful to you for this honor, and may God bless you, and may God bless you and make all your dreams successful. I have realized that when you told me, Dr. Dipti, that this is in continuity of the Safe Motherhood Day, I'll be covering some of the myths, and these myths I would like to blast in light of the latest knowledge and based on evidence. That is what I always feel, that your knowledge backed up by data is your biggest strength. And therefore, I selected today's topic as blasting the myths in obstetrics.
Yeah,
the topic is very vast, understandably. Do you know that before coming for an antenatal care, there are quite a few pregnant mothers who consult an astrologist on what muhurat they should go so that they get a favorable gender of baby at birth. So from there, all the myths start. And I'm not going to talk about the myths, about what patients or mothers practice, about what haunts us as obstetricians, and which will help you in your day-to-day practice to make it very scientifically competitive. And that is a job of a teacher. The topic is vast. I have only done some cherry picking and try to bring in things which can affect your life, because I only 30 minutes affect your practice. So first, straightway, let us start with first trimester. And let us revisit bed rest. The myths which are associated with bed rest, even with doctors who are prescribing bed rest, doctors who are telling for bed rest. Let us see. You can write down your answers in your paper next to you and then match with mine. You will not be able to send me, but what do you think? Do bed rest prevent miscarriages? Let us see the answer. There is insufficient evidence of high quality that supports a policy of bed rest in order to prevent miscarriages in women with confirmed fetal viability and vaginal bleeding. Even if she has vaginal bleeding but her fetus is viable, bed rest is useless. Please. So don't prescribe bed rest. I will repeat this again and again. Bed rest is bad rest. Let us come to another situation. For multiple pregnancy, so many times now with ART being so common, so many mothers we get with multiple pregnancies. This morning I had 3 multiple pregnancies in my outdoor, and all of the 2 had conceived by ART. And their constant question is, sir, do we require bed rest? Let us see what the evidence tells. There is currently not enough evidence to support a policy of routine hospitalization for bed rest in multiple pregnancy. In my residency, nearly 30-40 years before, we used to admit high-risk patients of multiple pregnancy only for rest. There is no reduction in risk of preterm birth or perinatal death because of bed rest. Until further evidence is available, this policy cannot be recommended for routine, your day-to-day clinical practice. So practitioners who are listening to me, bed rest for bleeding in first trimester means early pregnancy and a viable pregnancy also is useless. It is also useless for multiple pregnancy. Let us see one more. Bed rest in singleton pregnancy for preventing preterm births. This is our knee-jerk reflex. Aram karo, so jao, pet gumo mat. As soon as you suspect preterm labor, let us see what evidence tells us. This is all Cochrane data, solid, thousands of cases followed up. Although bed rest in hospital or at home is widely used as a first step of treatment, there is no evidence that this practice could be beneficial. This is how we blast the myths. Bed rest doesn't help preventing preterm births, but because we cannot We have to tell something, and out of our wits end, without knowing its nationality, we tell आराम करो, सो जाओ. गुजराती में कहते हैं सुई जजो, आराम करजो, परसों नहीं. नेक्स्ट वन, हाइपरटेंशन ड्यूरिंग प्रेगनेंसी. आपको हाइपरटेंशन है, एडमिट हो जाओ. आपको हाइपरटेंशन प्री एक्लाइमिंग, there is going to be a big panel discussion on this. I will only touch one aspect of this, and that is bed rest. It is not my job. I am sure the moderator will do a fine job. Very brilliant person is involved there. At present, there is insufficient evidence to provide clear guidance for bed rest and hospitalization during hypertension pregnancy. Therefore, bed rest should not be recommended routinely for hypertension in pregnancy. And we are talking of mild and moderate hypertension. If you have the courage, follow me, you will require, this is all science, and you will be required to fall back upon your scientific evidence again and again. Have the courage. For being courageous, you require to be honest, to be well read, and then have the courage, the truth power to share with others. Let us go towards fact and not towards myth. Let us see one more. There is one area in the first trimester which has raised lots of expectations, and that is 11 to 14 weeks scan. In fact, nowadays I am giving a lecture on titled The Can'ts and the Don'ts of 11 to 14 weeks scan by generalist. I am a generalist. I had used this word in many meetings, even the day before yesterday in Lucknow. We are generalists. On a typical day, I would suture an episiotomy, do a routine ultrasound scan, carry out an obstetrics, carry out a delivery, and deliver such a big uterus endoscopically doing a TLH. This can be my routine day as can be of yours. We are not general practitioners. We are generalists. And we are expected to do, and we can do 11 to 14 week scan. This is not a super fine sonography as done by our fetal medicine experts who are magicians. They do wonderful job. But we at our level can do, and that is where I am giving a lecture. Only one part of which I am covering here, and that is, and because one of the patients had actually told this, that sir, there was a low-lying placenta, you could not pick up. I am not doing 20 week scan, I do 11 to 14 week scan. And there is an expectation that 11 to 14 week scan must be able to identify low-lying placenta. Now let us see this. All that 11 to 14 week scan can do is to identify the size and texture. Placental localization in relation to cervix is not predictive at this stage. Just look at this. You can see the entire, it seems the entire placenta is covering, and here is the cervix. Now let us see. Progressively followed up. What happened? Here is the same cervix, and here is the placenta. This was the old picture. You can compare. Therefore, placenta previa should not be reported. Blast that myth at 11 to 14 weeks. Please do 11 to 14 week scan. If you find something is not comfortable, then refer to our fetal medicine expert. Yes, one opinion take from fetal medicine expert. I take at 20 weeks. Rest all other scans I do myself as a generalist. This was regarding the first trimester. We are continuing with some aspects of antenatal care. And let us visit, this is a very diverse topic. Iron and its side effects. The myth related to iron and its side effects. Let us see. Data has shown that an iron without gastric side effects is incompetent. If a company comes and tells you that their iron does not produce a side effect, that company is fooling you. In between, before around 20 years, we did get a molecule for huge profits to that company actually, and they said that it has no side effects. Actually, hemoglobin levels fell, and a prospective large study has proved that iron without gastric side effects is incompetent. Yes, the side effects can be ameliorated, can be attenuated, but will surely remain, because if you study the physiology of passage of iron through the mucosa, it itself has to produce an irritation. One more about iron. What about alternate days iron? When this is one of the steps prescribed for ameliorating the effects. A study around less than 10 years old. Available data indicate that in comparison with women receiving daily supplements, women receiving iron intermittently had a similar risk of anemia, had a similar hemoglobin concentration at term, had a similar risk of premature infants, had the same risk of delivering low birth weight infants, had fewer side effects, had a reduced risk of alarmingly high HB concentrations throughout the pregnancy. We don't want very high levels. They are very dangerous. So the message is intermittent iron may be a feasible alternative to daily iron supplementation among those pregnant women who are not anemic and are going to take up adequate antenatal care. So you can think of this. This is the myth which we have to visit, which was not being considered. This is no more a myth now. It is science. Dietary advice in pregnancy. Some new data has come regarding dietary advice in pregnancy. So much time is taken by dietary advice. Everyone wants to know क्या खाना चाहिए, सब कुछ खाना चाहिए, हमारा सर मत खाओ बस. Because pragmatic advice as to the conventional sources of food in that society and that culture takes care of most requirements of pregnant women. Please, pragmatic, practical, आप जो खाते हैं, therefore it is wisely said, let her take whatever her husband eats, albeit hygienic and clean. आपके husband जो खाते हैं, आपकी family जो खाती है, वो खाइए and that's enough. ज्यादा बिल्कुल advice की जरूरत नहीं है in routine cases. What about salt restriction in preeclampsia? So many of you reflexly, hypertension, there is going to be a panel. Always, they will surely throw more light on this. Always tell, restrict salt. Let us see what it tells. Our latest Cochrane database. In the absence of evidence that advice to alter salt intake during pregnancy has any beneficial effects for prevention of preeclampsia or any other outcome, salt consumption during pregnancy should remain a matter of personal preference. I am blasting the myth that you should restrict. No need. Whatever be her personal preference, let her continue. In fact, there were some studies around 15 years before which said that salt restriction actually in preeclampsia enhances IUGR. But that is not sustaining. But then I am just informing you of this. Let us go ahead. Calcium supplementation for hyper. Big discussion took place on this. Calcium supplementation is probably beneficial. 2022, hardly 3 years, 2 years before. Beneficial for women at high risk of hypertension in pregnancy and those living in communities with low dietary intake of calcium. Normally also you are giving calcium, so fine. Whatever preventive action it is going to take, it will take. Now let us come to some new data which has come regarding antihypertensive drugs. Which one? There are some myths which are going on. We decide our prescription habits as per the medical representative teaching us pharmacology. For a teacher like me, this is absolutely my failure. A teacher must be there to guide you and provide to share with you what is latest in this. Nifedipine or methyl-dopa, labetalol or hydrolazine. 2018 data has come and it has very beautifully shown that antihypertensive drug therapy for mild or moderate hypertension surely decreases the risk. People like Dr. Preeti, Dr. Sunita and all know that there was a phase where they said there is no need for mild to moderate hypertensive disorder pregnancy. We all knew this is nonsense. It is confirmed now that it is nonsense. And if antihypertensive drugs are to be used, beta blockers and calcium channel blockers appear to be most effective than all of the other alternatives in cases of severe hypertension. First, beta blocker assisted by, if need, calcium channel blocker. We come to the next area, preterm labor. Let us blast some myths there. Oral beta mimetics for maintenance therapy after threatened preterm labor. Threatened preterm labor, you give oral beta mimetic and then It just goes on and on and on. The threat is gone, everything till nearing term. You just forget about that isoxaprine or whatever it is. And what do you find the result? That patient just goes on taking it. How much is it helpful? Data shows. I am leaving my, for your queries, if you have any, I am leaving my email ID here. And this is my YouTube channel where if Dr. if Shashank will send me the video, I will put it there after 1 or 2 months because the queue is long. Oral beta mimetics for maintenance therapy. Available evidence does not support the use of oral beta mimetics for maintenance therapy after threatened preterm labor. Tocolysis for suspected intrapartum fetal distress. When you are waiting for cesarean section, that is the time. Can it help? Because the uterine activity is severe, baby is developing a fall, a dip. Can it help? Data shows that beta mimetic therapy appears to be able to reduce the number of fetal heart rate abnormalities and perhaps reduce uterine activity. So you can give. This is not a myth. This is a fact. I was asked this last week. One patient of who had a short cervix actually went in for preterm labor, and my biggest conscience is myself and assisted by my wife. We both challenge each other in a very healthy way. And she asked me, "Sir, what do you think? If we would have taken a cervical encerclage stitch, would this have been prevented?" Let us see the data. The use of cervical stitch should not be offered to women at low or medium risk of mid-trimester loss, regardless of cervical length by ultrasound. Regardless of cervical length by ultrasound. Just because you see that the cervix is short, no other reason for it, you start tying the cervix. No need. It will not help. Tocolytics for preterm labor. Success in the management of preterm labor is very much related to the initiation of treatment as soon as possible and administration of corticosteroid. Calcium channel blockers are preferred to other agents for stopping labor contractions. I will not go into the dosage because the full lecture, we all know 40 milligrams orally and then 20 milligrams, 2 or 4 for 3 doses, 2 only. But then this is not my job here, but calcium channel blockers are preferred. And yes, very much related because you are waiting time for the steroids to act. This will help you. Steroids will act 30 weeks, 32 weeks, your babies will have a safety. Prophylactic antibiotics for inhibiting preterm labor with intact membranes. So many respected obstetricians I have seen. And as a teacher, I'm just showing you the data. You, as soon as a patient comes in preterm labor, oh, this could be some infection. Oh, this could be some subclinical low-lying infection. And recently, being a peer of 3 international very reputed journals, including American Journal, European Journal, Fertility Sterility, I got one paper related to where a staphylococci infection can be ameliorated in patients and prevent the preterm labor. But current latest data says that prophylactic antibiotic treatment for preterm labor with intact membranes has no overall benefits in terms of neonatal outcomes. Therefore, be bold, be courageous. In fact, it increases the risk of neonatal mortality. Therefore, please don't unnecessarily give antibiotics. We come to labor, and here I am coming with a very new data, very latest data, a typical CTG picture. CTG, many of you are not using, but if correctly used, it is a very useful machine. Intrapartum cardiotocography improves neonatal outcome. That is the thinking of which CTG was sold to us, and many of us have given lectures. I have conducted full discussion sessions on this. But now is the time. 213,798 deliveries that met the inclusion criteria. The monitoring type was external transducer, and in 81,559, both external ultrasound transducer and maternal heart rate 62,268. A huge data. And let us see what they found. Alone cardiotocography does not help. If you want to do a cardiotocography, Combine it with monitoring of the fetal of the maternal pulse. This is something new. 2024. This article has just come. The use of external ultrasound transducer monitoring of fetal heart rate without simultaneous maternal heart recording is actually associated with higher rates of neonatal encephalopathy and severe neonatal acidemia. So please, next time you want to do a CTG, please combine it with maternal heart rate monitoring. And if maternal heart rate monitoring shows a tachycardia or anything which is not, you are not comfortable with it, this is not good. Till maternal, this is fine. You can rely only on CTG findings. But if maternal heart rate variability and maternal heart rate abnormality start, then be on the alert. This tells, use me, something underused. I don't know why it didn't become so popular, probably not very glamorous. Amnioinfusion for umbilical cord compression in labor. Does it help? Transcervical amnioinfusion does reduce the frequency of variable heart rate decelerations and reduces the risk of cesarean section. Therefore, it helps. I will not go into the details of amnioinfusion. It is there on my website, but we are only blasting the myths. Can we use amnioinfusion for meconium stent liquor? Does it help? Amnioinfusion decreases the risk of meconium aspiration syndrome, cesarean section, and neonatal morbidity. Available evidence supports its use in women with meconium stent amniotic fluid, even in under-resourced settings. So like some of our medical colleges as relatively inexpensive instrument for amnioinfusion are available. A simple Foley's catheter can be used. We are not going into the details, but while you are waiting for the anesthetist to come and you have seen that the woman has passed thick meconium stent liquor, do an amnioinfusion, dilute it out till the last returning fluid is clear, and the baby will have less chances of amniotic fluid of affection of the lungs. One labor room situation. Mrs. A young primigravida comes to in advanced labor, very practical situation. She has a deeply engaged head in second stage of labor. There is a thick meconium stent liquor, FHS bradycardia. What will you decide? Deeply engaged head, vacuum or forceps? Full dilatation. If speed of delivery is important, use of forceps result in a quicker birth than use of the ventouse without any compromise to the condition of the baby with similar rates of perineal trauma. Therefore, if speed is important, forceps, lest you can continue with your vacuum. Somewhere where time limit is very important. When to intervene? At 37 weeks or at 41? 41 was a concept somewhere in that when we had Agra AICOG. Risks of stillbirths or neonatal death 2020 increases as gestation continues beyond 40 weeks gestation. So no, beyond 40 weeks, no. This Cochrane data, 34 RCTs, 21,000 plus women. The trial compared a policy to induce labor after 41 completed weeks with waiting for labor and compared with waiting for labor to start or waiting for indefinite period. What they found? There is a clear reduction in perinatal death with a policy of labor induction at or beyond 37 weeks. So 37 cutout is fine. 40 plus 40 is out of question now in 2024. Obstetrics today on April 30th. After 37, you can start thinking of inducing. Nothing wrong. There was lower cesarean section rates without increasing rates of operative vaginal births, and there were fewer NICU admissions where the policy of induction was taken rather than passively watching till 40, 41. Don't let it go beyond 37 only. You can start thinking of induce. Not all to induce, but clinically, if you feel that this, so what is the preference now recommended by the labor induction at or beyond 37 weeks should be your policy over expectant management. This has got lots of ramifications, but by and large, this basically remains. We come to the last part. I have got only 5 minutes now. General myths. Let us see. creams can help avoid stretch marks. And I've seen many of you prescribing creams. You have to prescribe something, therefore most of you prescribe. What does data show? There is no evidence that creams or oils can remove or prevent stretch marks, which often fade over a period of time. You should have the courage to tell, ye chala jayega. Therefore, like this picture, it looks magical. Creams are not magical. And something where woman is very much despaired, all bleeding during first trimester means a miscarriage, while any bleeding during any stage of pregnancy can be alarming and scary, agreed. Data shows that vaginal bleeding is extremely common in first trimester, occurring in 20 to 40% of pregnancies. So don't be afraid. Do an ultrasound, and as I told you, if the baby is viable, even if there is spotting or bleeding, don't worry. Most of the time, she will go through. Last 2 minutes and I'll finish. What about coffee? We all love coffee. My children love coffee. Unluckily, I can't handle coffee. You shouldn't drink coffee if you are pregnant, if that is what people feel. While a pregnant woman should not drink any alcohol, she can surely enjoy a cup of coffee, but moderation is the key. I have seen now in IT people, I don't know why, so much coffee consumption takes place. Maybe I am getting this type of patients, therefore I have brought these things. In moderation, it is fine. So friends, in last 45 seconds, actually I have 1 minute and 45 seconds, it is impossible to cover all aspects. I can give one full, totally different myths explosion lecture. The policy should be scientific. Keep reading. I still read, honestly. This is not bragging. This is not telling lies. I never required to tell lies. I still read 1.5 hours at least per day. So therefore, be scientific or listen to such lectures where people will read for you and they will come and share with you. Ayn Rand, whom many of us are reading, has very wisely said, I have just finished her book after 40 years once again, that is Fountainhead. If you want to feel good, be rational and you will realize this. So to be a very scientific obstetrician, you should be alert at the latest developments, in full command of what is happening. Like our Balakwade was continuously on mobile. Be well informed and be well read. Then you can